Chapter 3, The VA Healthcare Delivery System by Elizabeth Yano, who works at the University of California and the Veteran Affairs Los Angeles Research and Development Center. This chapter, unfortunately, was written almost 10 years ago, and I suspect that a certain amount of it is out of date and inaccurate. But reading this article from 2008 to 2011 shows that the VA is huge. It's certainly one of the oldest direct healthcare systems in the United States. It was founded in 1636, and today it operates with over 143 hospitals, 1,000 outpatient clinics, 135 community living centers, over 50 domiciliary rehab programs. It employs over 250,000 people, including 13,000 physicians and 60,000 nurses, who help provide the over 60 million outpatient visits and 500 million inpatient visits a year. Now, the organization has undergone significant changes over the years and remains a subject of controversy. It started in 1936 as the first benefit system for Plymouth County of veterans who were disabled in that war. In 1776, it was expanded by Congress to include pension benefits for disabled soldiers. And the federal government established the first medical facility for veterans in 1811. Major expansion occurred in 1917 and the years following World War I, including care for outpatient and hospital treatments, pensions, and care for disabled soldiers. The Veteran Affairs Administration grew significantly during the Great Depression with capital projects in the building of hospitals and in the post-World War II demands. Elsewhere in the United States, between 1975 and 1995, there was a 12% decline in hospitals, as well as a shift to more ambulatory care. But this did not happen in the VA. In fact, they did not close hospital beds. And by the time the Clinton administration reviewed the VA in 1993, they found that there were 70% specialists to 30% generalist physicians, that there was almost no primary care, and primary care was being provided for the most part with a walk-in system. Because of these concerns and public debate over the last decades leading up to the 1990s, 3 out of 4 veterans indicated that they would vote with their feet and leave the VA if they had given the opportunity. The threat to survival served as a call to action. The VA then, under the 1990s, goes under a massive restructuring and prioritization of quality to try to improve their service. This started by restructuring the 172 independent VAs into 22 Veterans Integrated Service Networks, VISNs. In addition, multiple community-based outpatient clinics were opened, CBOCs, and these satellite clinics provided extended care outside of the main hospital. To show how fast these services grew, in 1993, only half of VA facilities said they treated the majority of their veterans in primary care practices, whereas within 3 years, this number had grown to over 80%. The VA was an early adopter of medical records in the 1990s and included decision support capabilities and primary care notifications. Performance measures were tied to high-value activities such as cancer screening or influenza vaccinations, and clinical order entry has been used as part of the VA system for the book said decades, which I do find a bit hard to believe, but that's what it says. In addition, patients are able to access their chart via MyHealth-eVet. National performance measures were set as part of the reforms. Patient care ratings were collected, and clinical quality programs were measured. And by 2000, the VA had improved in 12 of the 13 quality measures and was outperforming national averages for recommended care. They even created their own patient safety registry and patient safety rewards program prior to the Institute of Medicine's groundbreaking To Err is Human report. But despite efforts to improve the system, there does remain significant controversy around the VA. Depending on what study you read from the early 2000s when this book was written, VA cost can be either 20% lower than cost elsewhere in the US, or maybe 33% higher than costs elsewhere. The fact that these estimates vary by over 50% certainly has me question the validity of the data. Just a quick overview of the VA itself. Their membership included in 2007 around 24 million veterans, and a veteran is one who has been discharged from military service. 8 million were from Vietnam era and 5 million from the Gulf War, and women comprise over 7.5% of total members. At one point, there was a 2% cap as far as how many women could join the military, and now more recent numbers suggest 30% of recruits are female. Eligibility for coverage within the VA system is stratified and based on multiple risk factors. More broad coverage is for those who have disabilities related to service in the military, those who were former prisoners of war, and low-income veterans. The VA does support the most homeless patients of any system in the U.S. VA funding in 2009 was $100 billion, of which approximately half goes towards disability and income support payments, and the other half goes to medical care facilities and research. The 1997 Veterans Equitable Resource Allocation System was introduced and provided capitated funds that would follow veterans where they moved in the country, and this allowed new cities which were having new influxes of veterans to more rapidly expand their services. Throughout the 1990s restructuring, capitation models were introduced to each VISN, and the VISNs would be responsible for the budget and the financial accountability and quality of care by the organizations within the VISN. And each VISN would have between 5 to 7 VA hospitals, 25 to 30 outpatient clinics, 4 to 7 nursing homes, and 1 to 2 domiciliaries. And to reduce duplication of service, often 2 hospitals would be merged under a single leadership group. Services which could not be found within the VA, such as mammograms or specific procedures, would be contracted by the VA on an as-needed basis. In addition, the U.S. Treasury tries to collect insurance from veterans who have insurance plans, and this was totaling approximately $100 million a month when the textbook was published. The VA provides medical care in all 50 states, as well as countries like Puerto Rico, Guam, and the Philippines. It provides education and training, and in fact, 1/3 of residents, so 1/2 of medical students in the U.S. train at a VA hospital. Many VA hospitals are academically affiliated. In addition, research plays a significant part of the VA, and particularly research into conditions such as post-traumatic stress disorder, traumatic brain injury, prosthetics, polytrauma, and spine injury. The text says that, quote, past VA innovations were pacemakers, MRIs, CT scanner, and nicotine patch. I didn't know these were actually invented at a VA-associated institution. And in addition, the VA also provides contingency support and emergency management, meaning that in its connection to the Department of Defense, VA facilities and staff could be airlifted to provide direct care in conflict zones or to provide emergency support to Americans during a time of a local emergency. Outside of care provision, the VA also provides benefits such as medications, medical supplies, rehab, geriatric, and extended care. There are several special populations to consider within the VA. On average, veterans are older, lower income, in poor or fair health, and the population often has special needs, such as exposures to radiation, weapons, spinal cord injuries, blindness, PTSD, and homelessness. And despite having a functional status, which is the equivalent to having 2 additional chronic conditions, the VA risk-adjusted mortality is lower than their counterparts under Medicare Advantage. Mental health and substance abuse programs, unlike in other providers, are not capped in the VA system. VA also provides the largest spinal cord injury care network in the U.S., and as we discussed, women, which were a very small percentage of total recruits in the past, are now increasing in number, and therefore the VA is adapting the type of care it provides. To conclude, recent wars in Iraq and Afghanistan have also introduced new exposures, such as blast injuries from IEDs, and this has led to mild to severe traumatic brain injury, which has become the, quote, signature injury of survivors from these wars. In addition, up to 1/4 of recent veterans have mental health diagnoses. Some commentary. Unfortunately, as I said, this chapter isn't decade out of date, and I'm certain that there's continued to be criticism and transformation within the VA. The size of the organization in and of itself is certainly bound to draw criticism and also certainly bound to have bureaucratic sluggishness. And so I think it would be a bit of a tough time trying to sort out what is the actual truth as far as the quality of the VA system. I'd also be interested to learn how their IT system has evolved over the decades. I suspect that they have one of the largest data sets available for certain conditions.